So I'll begin by telling you how I first saw unmet needs, health disparities, and inequities up close, what that really looked like to me. In 2012, I began traveling across North Carolina, providing medical and psychiatric services to people with IDD. And as I began seeing patients in the counties you see circled here, I began to realize, wow, where the person lived, it really matters. If they live in or near a city, they may have access to great services and support, but it can be incredibly difficult to get the help needed if they live in a small town. Across the state, I reviewed medical records for when people with IDD were seen in an emergency department or in outpatient clinics. And I quickly recognized that many patients were not receiving the quality of care that a person without IDD receives. I saw that it was important to have preventative care, but that preventative problems and care for that was like being missed, being skipped. I saw overprescribing of medications. I could see that providers didn't seem to have a good understanding of IDD or weren't confident in providing that care. I heard parents describe how difficult that transition from adolescence to adulthood had been for their child, and that the lack of resources, particularly once they left school, was so difficult. How isolated their child became because of this was also a big concern. Sometimes I met families when their child was in crisis and they were having to make hard decisions, like for their child to move into a group home. I'll never forget one mom in particular who sat across from me in tears, and she said, "I feel like I have failed my son. We tried so hard, we had a plan, but it was not enough." I knew that she had not failed her son, and I reassured her of that I had heard many stories like theirs. They were not positioned for success. I heard families' frustrations about waiting for services, including the innovations waiver, and wishing they had learned about it sooner. I saw examples of families who were white, had more education, money, connections, that they seemed to be able to get plugged into services easier. It seemed much harder for people of color, or people with less time, money, or connections. Amazing mentors helped me understand that by getting a PhD and beginning to do research and health policy, I would be able to address these problems on a broader level instead of seeing them, case by case, day by day. So today, this is what we're going to discuss. First, I'll define and describe these terms. What are health disparities? What does the term intersectionality mean? What is health equity, and why is that our goal? We will share a bit about health disparities happening across the US, what we've learned in North Carolina through several of our research studies, and then lastly, we will share some projects that we're doing to address these problems and impact positively the health of the IDD community in North Carolina, and ways that you could potentially get involved. There are differences. We know that people with IDD are at greater risk for certain conditions based on their cause of IDD. For example, if you have IDD, you're more likely to have seizures. If you have Down syndrome, you're more likely to have heart problems. So we know a person with IDD has differences in their health that a person without IDD may not. But when we talk about health disparities, we are focusing on what is preventable and necessary to help people reach their best health. The CDC defines health disparity as the preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So Healthy People 2030 spells it out even more. They say health disparity is a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. Without that disadvantage and with the right supports, people would be much healthier. So we know that health disparities adversely affect groups of people who have been systematically experiencing greater obstacles to their health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation, gender or identity, geographic location, or other characteristics that are historically linked to discrimination or exclusion. We just want to make sure that we are talking about the same terms and that we are using that in the same way. There are 5 main domains that affect health. These are where the obstacles to health happen. The healthcare setting and healthcare access and quality listed at the top is just one of the domains. Medical care is estimated to only account for about 15% of modifiable contributors to healthy outcomes for a population. So we know that a person's social connections and community, having enough money, their access to quality education, and having a neighborhood that is accessible is crucial for health. These are social determinants of health, and they are the conditions and environments in which people are born, live, learn, work, play, age, etc. And they affect health, functioning, quality of life, all the things we really care about. And here you're going to see that there are 2 main ways that we examine health disparities. We are concerned about health disparities when comparing the general population to the population of people that has IDD. We know that if you have IDD, you are more likely to receive poor quality of care, have less access to care, have worse health outcomes, are less likely to be employed, and many lack the social opportunities that you may need to be healthy. We're also really concerned, though, when we compare groups within the IDD community. So, for example, people from historically marginalized communities like people of color or indigenous people and people living in rural areas are more likely to experience obstacles to living a healthy life. Then we think about the age groups. There are particular periods of development that are particularly vulnerable. So when we think about the transition to adulthood, we know that it's a difficult time for adolescents and young adults, and it's particularly difficult if you are from a racial and ethnic minority community. Again, most at risk for poor health, worse outcomes during that transition to adulthood that is so important. In 2020, the life expectancy for the general population was 77 years of age. But for example, people with Down syndrome have a shorter life on average, as they typically live closer to 60 years of age. The good news is that is much longer than it was in 1983, when the average lifespan was around 25 years. And again, those domains that we just reviewed, because of improvements in all those areas, quality of life and length of life has improved, but we still have so far to go. Mortality rates among adults with IDD are much higher than for the general population, with over a third of death being preventable, potentially preventable with healthcare intervention. So that highlights that things are being missed, and people are suffering unnecessarily. An example would be pneumonia that is missed. That could be a common cause of death. So people in racial and ethnic minority groups and communities are most at risk for poor health and less access to disability benefits, community services, routine care, when compared to people who are white and have IDD. One final example I want to give you is with children. If a child is Black or Latino with autism, they're more likely to get diagnosed later, have lower quality of health care and less access to care compared to children with autism who are white. And I want you to see, I'm trying to show you here what intersectionality looks like. This is a fancy term that really means that and reminds us that everyone has their own unique experiences of discrimination and oppression. And the ways our society identifies us in these different ways, they overlap. And as you can see here, can cause people to have even greater disadvantage. So one example I'll give you is a Black woman who is queer and is disabled is even more likely to experience the disadvantage and health disparities that I've been describing. So I'm sure you're wondering, what is causing this? What is causing these disparities in care and services? There are 3 really big ones. 1, lack of educational preparation and the experience of healthcare providers to do this work. Number 2, stigmatization, discrimination, and segregation towards people with IDD. And third, institutional and cultural racism towards individuals who are also from racial and ethnic minority groups. So health equity, remember that term if it's new to you, health equity. It's super important. It's our goal. Achieving health equity requires addressing health disparities and removing these obstacles to health. Removing these obstacles that I've described: poverty, discrimination, lack of access to good jobs and fair pay, quality education and housing, safe environments, and quality healthcare, so that everyone has a fair and just opportunity to attain their highest level of health. And as you see with the picture in the corner, we need equity, not equality. Some people need more supports to be able to have a fair and just opportunity to be healthy. In this picture, it means to see over the fence. To see over the fence is an example that here would mean having a full and healthy life that they deserve.